gosh, I don't know what time this is, but we've been doing this for probably 15 to 20 years with Dr. Pujari coming to grand rounds and helping us out. But it's my pleasure this morning to introduce Dr. Astrid Pujari. Dr. Pujari trained on the East Coast at Tufts for medical school, and then kind of went straight across the country to La Jolla to Scripps to do her internal medicine training. And after her internal medicine training, flew all the way to England to do training at the Royal College of Phytotherapy, where she was certified as a medical herbalist. She came back, and not long after that, I don't think, probably started at Virginia Mason, but she's boarded in internal medicine, but also in integrative medicine. And she's done a great job for years helping us understand all aspects of the integrative part. And today she's going to talk about intermittent fasting, which I thought was a fascinating topic. And thank you, Dr. Pujari, and go ahead.
Thank you so much for being here. It's really my pleasure to be here today. And as you know, as Dr. Nietzsche shared with us, we're going to be discussing intermittent fasting today. I put this picture, by the way, of an emperor penguin on the front slide because emperor penguins actually fast 5 months of the year while taking care of their chicks. So this is our model for today. Okay, so what's the background on intermittent fasting? Actually, a lot of the interest in the medical community, I think, started with this New England Journal of Medicine in 1997, which was around caloric restriction. And what this New England Journal of Medicine talked about was that caloric restriction through the life of animals had a noticeable effect on aging with an increase in lifespan. And the thought was that potentially it was related to a drop in free radicals. So it turns out that there are cellular mechanisms of protection that have evolved over billions of years. And it makes sense if you think about it, because when we were hunting or we were hungry, we also needed our bodies to suppress those free radicals or other damaging molecules so that we could do that effectively without developing age-dependent damage on our cells. So these cellular mechanisms of protection have evolved over billions of years, actually in many systems of life. So if we look here, bacteria, for example, they have a half-life of 36, when they are under caloric restriction, they will drop they'll increase their lifespan from 36 hours to 84 hours. Yeast go from 15 days to 40 days. Worms from 25 to 40 days. And mice from 120 weeks to 200 weeks, which is really kind of remarkable. And this, you can see the reference there at the bottom. So in addition, meta-analyses of caloric restriction studies, which span quite a long time, you can see there, increase the lifespan in rats by about 30% and increase the lifespan in mice by about 20%. And there's another study showing that the average lifespan in rats increases up to 80% with what's called alternate day feeding, which is another kind of fasting. So, of course, it depends on the age, the diet, the sex, the genetics, and it's not universal, so it depends on the study, but these are interesting points. So more recently, people have asked themselves, well, is it really just caloric restriction that's causing these improvements, or is it actually fasting? And the reason for that is because, as it turns out, when you feed a mouse in a cage, it gobbles down all of its food within the first hour, and then the rest of the time it spends fasting. So it's kind of hard to know, well, is this from fasting or is it from caloric restriction or both? So let's define all of this for today. So caloric restriction in studies really refers to basically daily caloric restriction. So what a lot of people like to call being on a diet in traditional terms. So you're basically reducing calories 20 to 40%, but you're maintaining your meal frequency. Fasting means that you have no or minimal amounts of calories, food, or drink for a period of time. Traditionally, that is 12 hours to 3 weeks. Now, Why traditionally? Because in many religions or cultures, fasting is a part of the culture, and it depends on the culture what amount of time that is and how it's done. Intermittent fasting is basically when you switch between eating and fasting on a recurrent schedule. And starvation, of course, is chronic nutritional insufficiency, which occurs from extreme fasting. So it results in degeneration and death. So caloric, basically decreasing calories happens with all of these. So caloric restriction, meaning being on a diet, intermittent fasting, and fasting. It occurs with all of those. And that being said, so it's a little confusing because when you look at studies, it may say caloric restriction, but actually caloric restriction also happens with intermittent fasting and it happens with fasting. It's just that you're keeping your meal frequency with daily caloric restriction. Intermittent fasting, though, has become popular with patients because the weight loss is seen as equal to daily caloric restriction or being on a diet, but it seems easier for many people to do. So I've seen in my own practice, for example, even though this knowledge has been there for quite a long time, it's become very, very popular probably in the last few years. The three most commonly used kinds of fasting are alternate day fasting, which basically means you go from 5 days of eating to 2 days of fasting, and you can disperse that out however you want during the week. Or forgive me, alternate day is every other day. So let's say Monday you eat, Tuesday you don't eat, Wednesday you eat, and then 5-2 is just what I shared. So you have 5 days of eating and 2 days of fasting. And then daily time restricted eating is very, very popular right now. And that basically is when you're fasting during a window. So 16 to 18 hours is the average, what I commonly see, although officially in studies it's defined as 12 hours or more. And you're eating within a window of time, so 6 to 8 hours. So what happens during fasting? During fasting, basically our liver glycogen slowly depletes over 12 to 24 hours. And of course that depends on activity level and on the person. And what happens then is we use our fat to take those triglycerides in the fat and change them into glycerol and free fatty acids. We break those triglycerides down. The fatty acids then are converted by the liver to ketone bodies. So in the fed state, we have a very low minimal level of ketones. And in the fasting state, by 8 to 12 hours, ketones start to occur. And then by 24 hours, we get a 0.5 to about a 0.5 millimole level. And by 48 hours, we have 1 to 2 millimole level on average. So basically, ketones start at about that and go to about those levels. So what are the effects of ketones on the body? Ketones are not, as it turns out, not just fuel. They are actually powerful signaling molecules that affect cell and organ functions. So let's look at this in a little bit more detail. Here's a kind of a rendition of cellular metabolism, and we're just going to use beta-hydroxybutyrate here as one of our common ketones in humans. And let's look at this in a little more detail. So if you look here on the side of the slide, what beta-hydroxybutyrate does when it goes into that electron transport chains, it actually influences the electron transport chain so that there's a decrease in superoxide radical generation. So basically you're getting a decrease in radical formation or oxidative damage. In addition, it influences the Krebs cycle so that you get an increase of generation of NADPH. NADPH then allows for an increased amount of reduced form of glutathione, vitamin C, vitamin E, thioredoxin. So you're basically getting, when those things are reduced, they're going to be more available and more effective for quenching oxidation. So effectively what we have here is we have a drop in oxidative damage and we have an increase in our antioxidant capacity at the same time, which then protects the cells from damage. In addition, there's an increase in the reduced form of dihydrobiopterin, which basically increases the generation of melatonin and neurotransmitters, which may explain some of this effect on cognition, which we'll go into basically right now. So what are the effects of fasting on cognition? And in mammals, as it turns out, food deprivation shrinks the size of all organs except for the brain and the testes. And actually, this makes sense. So if you look at a wolf, I was actually doing research on wolves, they only eat about 2 times a week. So if you have a wolf and it's only eating 2 times a week, the rest of the time effectively it's fasting. But when it's hunting, it needs to be able to think and have its cognitive function excellent to be able to hunt, right? So there's an evolutionary need for high cognitive function when animals are looking for food and they're hungry. And the same applies to mice. So if you look at these studies on alternate days fasting, with what we'll see is there's an increase in cognitive function in rats. They have an improvement in behavioral tests of motor and sensory function while fasting. They have an improvement in learning and memory, and they actually have an increase in synaptic plasticity with fasting. In addition, in the brain, so we're going to go into cellular mechanisms in a little bit more detail here, beta-hydroxybutyrate actually binds to a receptor called HCAR2, which stands for hydroxycarboxylic acid receptor 2. And that particular receptor is high in the substantia nigra area of the brain, for example. It's not the only place where it is, but it's high there. So as we know, that's important for Parkinson's, so in terms of clinical relevance. So when beta-hydroxybutyrate binds to HCAR2, one of the things that happens is it inhibits the generation of NF-kappa beta, which we're all familiar with as an inflammatory molecule or cytokine. So what that does is actually beta-hydroxybutyrate actually drops, and ketones drop NF-kappa beta through the body. But from a brain standpoint, it also decreases neuroinflammation, which is thought, inflammation, as we know in the brain, is thought to be one of the underlying issues with neurocognitive disorders. In addition, now looking to the other side of this slide, beta-hydroxybutyrate, when it binds HCAR2, actually increases the generation of SIRT1, which is a deacetylase. And that particular deacetylase has a strong association with health and longevity benefits. So what does it do? It actually increases something called autophagy. Say that quickly 5 times. It was quite a word, but it increases autophagy, which basically in this case means recycling of damaged mitochondria. Remember that damaged mitochondria, again, is thought to be an important mechanism for how neurodegenerative disorders occur, like Alzheimer's or Parkinson's. So when we accumulate damaged organelles and damaged cells in the brain, that's not good for the brain. And we'll go into autophagy in a little bit more detail in a moment. Actually, ketone generation will improve autophagy through the whole body, not just through the brain. And not just of mitochondria, but of cells and other organelles and proteins. So one thing that SIRT1 does, however, in the brain is increase autophagy, meaning recycling of damaged mitochondria in the brain. It increases mitochondrial biogenesis. So it increases, let's say, new mitochondria development in the brain, which is, of course, important for prevention of neurocognitive disorders, at least mechanistically. It increases transcription of antioxidant genes, so we're seeing this again where we're dropping oxidative damage in the brain, and it protects against the apoptosis of neurons through affecting p53. So we're decreasing cell death in the brain. So as I shared, let's talk about autophagy for a moment, which basically in the Greek just means eating of the self. So the way I like to think of it is we have a trash system in our body, and we need to put, if we accumulate trash in our body, it's not good for our body's health. That kind of makes sense. But really maybe the better way to describe this is recycling. So we take old cell components and old cells, stick them into lysosomes, and we recycle those components for energy. And this can be, beta amyloid protein. It can be lots of different proteins. Dr. Oshumi actually received the Nobel Prize in Medicine and Science in 2016 for describing more about autophagy and explaining to us more about this. The impairment of autophagy is linked to various diseases, as I've shared, so neurodegenerative disorders like Alzheimer's and Parkinson's, cancer, non-alcoholic fatty liver disease. So there's many different disorders that have been linked to impaired autophagy. And autophagy is increased, meaning improved, with caloric restriction and fasting, as well as other things, including physiologic stress. So going back to how do ketones improve brain function, so we're going to skip back to that for a moment. There's a compound that is made called brain-derived neurotrophic factor, or BDNF, which actually has been shown to promote growth in neurons, enhance synaptic plasticity, increase the resistance to injury in the brain, and improve neurogenesis, learning, and memory. In animal models, it is protective against Alzheimer's disease. We know that higher levels of BDNF in the brain affect the autonomic nervous system. And when we have higher levels of BDNF, we actually have an improvement of parasympathetic tone. So, of course, with higher parasympathetic tone, what's going to happen? We're going to have a drop in resting heart rate, and we're going to have a drop in blood pressure, similar as we would to exercise. It also, interestingly to me, improves gut motility. So BDNF increases with exercise. In fact, this is why if you've read studies, for example, in schools, adding exercise actually helps with school performance in many dimensions, testing, etc. But in addition, fasting, interestingly, you'll see similar drops in heart rate and blood pressure as you do with exercise, probably from this improvement in parasympathetic tone. So as a review, what we've talked about so far is with fasting, we're going to have an enhancement of network plasticity in the brain, increased neurotrophic factors, improvement of something called stress resistance, which I'll go to in more detail in a moment, mitochondrial biogenesis, reduction of oxidation, and reduced inflammation. In addition, we have an improvement in parasympathetic tone, improvement in resting heart rate variability, and blood pressure. And naturally, and I think honestly this is I didn't go into a lot of detail around this because I think it's sort of obvious to many of us, but that we would naturally get an improvement in insulin sensitivity and glucose metabolism with fasting, and decreased IGF-1 levels, which, as we know, IGF-1 levels then in studies, observational studies, will correlate, for example, to increased generation of cancers, etc. So intermittent fasting then, in terms of effects, has been shown to improve autophagy, biogenesis of mitochondria, improved glucose metabolism, decreasing of inflammation, and improvement of cell survival. Now let's talk for a moment about this concept called stress resistance, which in a way is unique to fasting, particularly alternating with eating. So if we look at studies, and just to kind of look at this in a little more detail, when we eat, we're going to get a bump naturally in glucose. So let's say in that top part of the slide, we're eating 3 meals a day. So we're going to get a bump in glucose 3 times a day with our food. And naturally, our ketone levels then are going to stay at a constant, fairly low rate overall. Now, if we're fasting, meaning if we're alternating fasting and eating, that's alternate day fasting, or we're doing a 5-2 schedule where it's 5 days of the week eating, 2 days fasting. What we're going to see here is, as we shared, at about 8 to 12 hours, we're going to start to see a bump in the ketones, and then when we eat, naturally, we're going to drop back down and use glucose. And similarly, if we're doing what's called time-restricted eating, we're going to have, so we're fasting, let's say 16 to 18 hours a day, we're going to again start to see a bump in those ketones at around 8 to 12 hours, and then with eating, it's going to drop back down as we switch to glucose metabolism. So effectively what we're seeing here is we're seeing a metabolic switch, what in studies is frequently called flipping the metabolic switch. We're flipping between the glucose, using glucose for fuel to ketones for fuel. Glucose for fuel, ketones for fuel. Glucose for fuel, ketones for fuel with fasting, depending on the type. So from this New England Journal of Medicine, which did a really nice review, they described that with this metabolic switching or flipping the metabolic switch, what happens during the fasting period is we have increased resistance of the cells. They're resisting basically because they're under stress. So again, those mechanisms for dropping oxidative damage, dropping inflammation, improving antioxidant status, all tissue and repair and removal, all of that happens during the fasting period of time. Then during recovery, when we're eating, then we have cell growth and plasticity. So effectively, we are getting a long-term adaptation if we're switching back and forth between that, where we have over long term, we're getting an increase in insulin sensitivity, improved heart rate variability, improved lipid metabolism, an improvement of gut microbiota. What does that mean or translate to? This is very complex, actually, gut microbiome, but basically, simply put, it improves diversity, which correlates to a lot of different health benefits. Reduce visceral adiposity, and which, of course, is very important for inflammation reduction and reduction of blood pressure. So basically, we're improving resilience of the body. The way I like to think about it is similar to exercise. So if you think about exercise, it's calculated physiologic stress. So let's say we go running once a day, 30 minutes. What we're doing there is we're putting our body under stress for 30 minutes, right? And then we're in recovery, let's say the rest of the day. And so each day we're doing calculated stress and then recovery, calculated stress and then recovery, calculated stress and recovery. And with that, then we develop over the long term resilience in our body, so our resting heart rate drops, our blood pressure drops, our heart rate variability improves, our insulin sensitivity improves, similarly to what we've just described. So again, from this New England Journal of Medicine, DeCabo, the author, says, repeated exposure to fasting periods results in lasting adaptive responses that confer resistance to subsequent challenges, similar to exercise. So now the next question is, how frequently are Americans eating? Which is an important question, right? So it turns out that if you look at this big study from the American Journal of Clinical Nutrition in 2010, they had, at that time in the 1970s, we ate 3 meals a day, and there was no snacks. And I grew up like this, so it was sometimes a little bit difficult, but there were no snacks. And then we see that by 2004, we'd started to change our culture, so we were tending to eat more like 5 meals a day. Well, as it turns out, very interesting study. This study was done using a smartphone app, so people would actually enter in what they were eating, what time, how much, etc. And based on this study from 2015, we can see that the amount of time people are now spending eating has increased to 15 hours on average per day. And the amount of meals is people are eating about 10 times a day. So that translates to eating, if somebody started eating, let's say at 8, they don't finish eating until about 11 p.m. So what are the effects of that? Basically, as we've shared, fasting enhances pathways to decrease oxidative and metabolic stress and remove and repair damaged molecules. Feeding increases cell and tissue growth. So in the US, if we're eating more than 3 meals a day, often 10 per day, we're eating about 15 hours a day from 8 to 11 p.m. The only time effectively we're not eating is while we're sleeping. So we get a very limited time for repair and removal. So now let's talk for a moment about caloric restriction versus intermittent or time-restricted eating. Does it really matter? Meaning, all of these techniques will generally lower calories. So is there any benefit beyond just lowering calories? Well, one difference, as we've just shared, may be the metabolic switching. So with daily caloric restriction, we're still eating the same meal frequency, and we're getting less of that metabolic switching effect. So that development of stress resistance may not happen in the same way. The second, interestingly, and we'll look at some studies on this, is that with daily caloric restriction, meaning just being on a traditional diet, if you will, where we drop our calories, let's say 500 kilocalories per day, or depending on the diet, what's going to happen is we actually get 1/3 to 1/4 of that weight loss is actually lean body mass. So as we see in this study from 2011, it was a review of caloric restriction. So depending on the study, they dropped from 15 to 60% calories, keeping the same meal timing. And they compared that to alternate day intermittent fasting. So every other day they were fasting for 12 weeks. And what we see here is that there was an equal weight loss amount of about 4 to 8%, and similar fat mass loss, which is good. But with the intermittent fasting, people kept more lean body mass. In addition, in this study in 2018, it's a review of 8 studies, both caloric restriction and intermittent fasting, similarly, people lost an equal amount of weight and fat mass, but with fasting, particularly time-restricted eating, people tended to keep their lean body mass. So why does lean body mass matter? As it turns out, lean body mass is very important for increasing calorie burning at rest, so what's called resting energy expenditure. So, we've all had patients come to us and say, because I talk to people about their diets every day, many people will say, I've plateaued. My weight loss is plateaued. They're on a diet, and their weight loss is plateaued. The part of the reason for that plateau may be because as people are on, let's say, a traditional diet, what happens is they drop lean body mass, and so the resting energy expenditure at rest, meaning how many calories they burn at rest, drops as well. So they're actually burning less calories at rest. And so that may contribute to that plateau in weight loss. In addition, lean body mass is very helpful for preventing the risk of osteoporosis. So if we have more lean body mass, we have less risk of osteoporosis. In addition, it improves insulin resistance, not surprisingly. And there's this interesting study from the Journal of Clinical Metabolism in 2011 with 13,000 patients showing that every 10% increase in skeletal muscle mass decreases insulin resistance by 11%, which is really great. I mean, when we're thinking about, let's say, non-alcoholic fatty liver disease and all of the things that go with insulin resistance, heart disease, diabetes, obesity, there's a lot of benefits there. There's this study in terms of potentially there's a metabolic benefit. In 2013, they took 115 women who were overweight for 4 months. They did 25% calorie restriction, so either as a diet, meaning they dropped it just traditionally with daily caloric restriction, or they compared it to various forms of fasting. And with intermittent fasting, there was more fat loss, improvement in insulin resistance improved more significantly, and they maintained their weight loss more effectively in the last month of study. This is controversial, though, because there's other studies that may suggest that they're equal. So the metabolic benefit, I think, is a little bit less clear. So in summary then, comparing, let's say, being on a diet to fasting, you do get the benefit potentially of metabolic switching. You may get an improvement of lean body mass, although the studies are still small. And I think a little more controversially, for sure, there's a potential benefit in these other aspects of metabolic benefit. So another question I get a lot are, well, are these benefits of fasting just related to weight loss, or are they related to something else? And the answer for me really is, well, maybe they are related to weight loss, but there are some suggestive studies that I'd like to go through with you. Very interesting. I really like this study. This is from 2018. It was very well done. They took men with prediabetes or impaired fasting glucose, and they supervised every single meal they had for 5 weeks. And each meal had an equal amount of calories, and it was exactly the same. So the only difference was the timing of it. Either they had the exact same meals, same calories, but either they ate in a 12-hour window between 8 to 8, or they ate between, basically they did time-restricted eating in an early way, so they ate between 8 to 2. And with the early time-restricted eating, so exactly the same calories, exactly the same meal, there was a large drop in the mean insulin levels, 26 milliunits per liter. The higher the baseline of the patients, the more drop they had. So I really like that part because, you know, from a clinical standpoint, that's very relevant to me. Also, the mean insulin levels stayed 25% lower even in the 7-week washout period, which I thought was very interesting. There was a drop in blood pressure of about 10 millimeters of mercury. There was a drop in measures of oxidative stress, and a drop in appetite in the evening. So when we eat may be actually just as important as what we eat because of its effect on our hormones. So there's this study from 2013 with women who were overweight with a BMI of about 32 who had metabolic syndrome, and they were placed on a 1,400 kilocalorie diet for 12 weeks. And again, the only difference was they either had half of their calories in the morning for breakfast, or they had half of their calories at night for dinner. That was the only difference. Otherwise, they were on the 1,400 kilocalorie diet. The women who had more of their more of their calories for breakfast had 2.5 times more weight and waist circumference loss, which of course is a measure of visceral adiposity. And then that correlates, as we know, to inflammation and various metabolic effects. There was a drop in triglycerides by 33% versus an increase of 14% with the women who ate at night. And the area under the curve for insulin response was 25% lower if they ate their food for breakfast. I should say half of their calories for breakfast. So again, when we eat may be just as important as what we eat. There's these other two studies here that I put for reference, which again makes this point that eating the same food at dinner versus at breakfast, you get on average 25 to 50% more insulin effect. And of course, we all know from our diabetic patients who are on insulin, insulin translates to weight gain. So it makes sense then that if we're getting more of an insulin effect by eating more food at dinner, we're going to have more weight gain, just practically speaking, even from clinical experience with insulin. So ideally, if people are doing time-restricted eating, they would have that restriction sort of more in the morning hours. Now, I have to say on a practical level, this, in our modern U.S. style of, our culture, working with patients, it can be very hard to do this. So many people still end up doing a later window because, they want to eat with their families. But in the ideal world, we would do time-restricted eating if we were going to do it earlier in the day. So now let's talk about clinical applications. In human studies, most of the studies for cognition are actually on caloric restriction. They're not as much on intermittent fasting. We don't have as many studies on that. However, let's talk about caloric restriction first. So in this study from 2009, basically what they did is they took 50 normal weight to overweight patients, and they were in the 50s to 80s. And they compared caloric restriction of 30% to unsaturated fatty acid consumption diet, that had a diet high in certain unsaturated fatty acids, versus control for 3 months. And what they saw was with caloric restriction, there was an improvement in verbal memory, as well as a drop in high sensitivity CRP and insulin levels. And that drop in inflammation, again, is what we would expect with caloric restrictions from the ketones. In addition, this study in 2016 had 80 overweight patients with mild cognitive impairment with a BMI of about 35. Their age was 60 or above, and they did caloric restriction, basically 500 kilocalories for 12 months versus control. And both groups exercised. The weight loss actually, interestingly, was minimal, so it's likely not related. Those effects were likely not related to weight loss. And what we saw was an improvement in verbal memory, executive function, global cognition in the patients with mild cognitive impairment. The caveat here was that when I was reading the study, the patients who were on the caloric restriction actually got nutritional counseling, so improving fruits, vegetables, and fiber as a result. And of course, we know the Mediterranean diet affects cognition too, so that is a caveat here. Another study on caloric restriction for improving cognitive function was this one in 2019, which is a multi-center randomized control trials of 220 normal weight healthy patients, and they compared caloric restriction of 25% to an ad-lib diet for over 2 years. And they did neuropsychiatric testing at 12 months and at 24 months. And they saw an improvement in working memory. Lastly, there's this study. This is one of the only ones I could find on intermittent fasting. And it was a study of 99 patients with mild cognitive impairment of Malay ethnicity. And they compared regular fasting to irregular fasting to control. And this fasting that was looked at in the study was Sunnah fasting. So they, in their tradition, fasted from sunrise to sunset, Monday through Thursday. And they had this really interesting outcomes measure, which they defined as successful aging. It was a constellation of a number of different outcomes, including an improvement on MMSE, improvement in activities of daily living, and no evidence of the top 6 chronic diseases, so hypertension, diabetes, cancer, lung, or heart disease. They did use validated cognitive scoring scales. These are only some of them. So in terms of the results, with regular intermittent fasting, so people who really followed that Monday through Thursday, no food from sunrise to sunset, they saw over the 3 years, they saw 24% reverted to what was called successful aging as defined that I just went through. They also saw, interestingly, an improvement in cognitive scoring. With irregular intermittent fasting, there was an improvement of 14% to successful age, or reversal to successful aging of 14%, and with controls, 3%. So this is the study that I could see on intermittent fasting. I do think we need more studies, but interesting. I get a lot of questions about cancer and fasting in my practice, and basically the effects are inconsistent in animals for prevention of cancer and also for treatment of cancer. There are studies underway, which I'm very excited about. So there's a couple studies, one on metastatic breast cancer, another on metastatic prostate cancer, and another for preventing recurrence of breast cancer. So we'll see what those show. Mostly, though, what we have so far are some small studies on preventing side effects of related to cancer treatment. And they are small studies, but they're interesting. So this study from 2015 was one of 13 stage 2-3 breast cancer patients, HER2 negative, on standard chemotherapy. And basically they fasted 24 hours prior to chemo and 24 hours after chemo. versus the control. And basically in the fasting group, they saw less hematologic toxicity, so higher erythrocyte levels and higher platelet counts. And the fasting was well tolerated. In another study on 30 patients with gynecologic cancers, again on chemotherapy, they did a 96-hour fast prior to chemotherapy compared to ad lib eating. And in the fasting group, they saw less headache, weakness, stomatitis. The toxicity score dropped, and there were less chemotherapy delays. In addition, I will say there was no change in neuropathy or fatigue, which we know are common side effects, but there seemed to be some drop in side effects and toxicity score overall as noted. A number of questions I get about this is there a concern for weight loss? So far in the studies, this hasn't been a concern, but I think that's something that continues to need to be monitored, of course. For multiple sclerosis, it's another, because going back to that potential benefit for neurocognitive issues, there was a pilot study in 2016 looking at 60 patients with relapsing remitting MS over a period of 6 months period of time. They compared ketogenic diet to fasting for 7 days to, and then after that fasting for 7 days, they went to the Mediterranean diet versus control. And the results were that in the ketogenic diet, there was 1 relapse during that 6-month period of time. During the fasting, or in the fasting group, there were 3 relapses, and in the control, there were 4 relapses. Also, in the ketogenic diet and the fasting groups, there was an improvement in quality of life scores, and there was an improvement in standard disability scores. There is a study that, again, I'm pretty interested in called the NAM study that is underway. It looks very well designed that will compare the ketogenic diet to fasting to a low-fat diet for 18 months. So that should be interesting to see. For rheumatoid arthritis, a lot of this comes from, actually, there's observational data mainly from Scandinavia, interestingly. There's a lot of interest in it there. But there is this study from 1991 of 27 patients with rheumatoid arthritis. And what they did in this study is they started with a 7 to 10-day fast, and then they switched to a gluten-free vegan diet for 3 months, and then they switched to a vegetarian diet for 9 months. So effectively, they did fasting type intervention and then vegan and vegetarian for a year. And with the fasting vegetarian combination, there was a drop in the number of tender and swollen joints, as well as a drop in pain, a drop in morning stiffness, an improvement in the CRP and the SED rate, and improvement in this articular index. Versus in the control, there was only an improvement in pain. So overall then, in terms of studies, what we see is there's some preliminary studies that suggest benefit potentially for cognition. More of the studies have been done on caloric restriction than intermittent fasting. In an interesting study on multiple sclerosis, although there are going to be, studies are underway currently. Cancer, most of the data so far is really on prevention of chemotherapy side effects, and those studies are small. But there are some studies underway for prevention of recurrence and potentially treatment of cancer for metastatic cancers, for those higher volume cancers. And then rheumatoid arthritis, there are a number of observational studies that I didn't put in that do suggest fasting generally improves rheumatoid arthritis symptoms. It's thought because with fasting, you're going to get a significant drop in inflammation that during, that fasting helps with those arthritis symptoms. However, again, it's interesting, and I think we still need more studies. So another question I get a lot from patients is, well, can I just do the ketogenic diet? Is that the same as actually fasting? So ketogenic diet is a whole topic in and of itself, and we really don't have the time right now to go through all that. But basically, the ketogenic diet's very, very high in fat, and then moderate in protein, and then very low in carbohydrates. So what happens with that diet is you get, a high amount of ketones. In fact, that's the goal, is to switch the body over to using ketones for fuel instead of glucose. So entirely switching over to ketones, and meaning long term. And so there really is no metabolic switch then, primarily. With the ketogenic diet, you're really entirely trying to rely on ketones. Obviously, a lot of people don't do it perfectly, so you may be getting some metabolic switching, but the goal is primarily ketones. So the difference then would theoretically, although, again, some of these multiple sclerosis studies and other studies should help elucidate this better. But it does seem that with the ketogenic diet, because you're not getting that metabolic switching, that flipping back and forth between glucose and ketones, you're not going to develop that stress resistance in the same way. In addition, there's some in vitro studies that suggest it may not be as good for autophagy, but that's really unclear in terms of in vivo, so that still needs to be elucidated. So what are the contraindications to fasting? And I think these will be fairly obvious to many of us, but obviously if we're pregnant, breastfeeding, if there's diabetes, if you have a low BMI, if there are eating disorders, certainly we need to be careful about any kind of diets or dieting, and or nutritional restriction. And for children, this would not be appropriate. And again, in summary, here's our model for fasting is the emperor penguin who fasts 5 months a year to feed its chicks. Thank you very much for your time today.
Thanks, Astrid. That was wonderful as usual. There are several questions. One is that came in fairly early on is if you were going to prescribe intermittent fasting, what would your prescription look like? What are the more detailed? How would you say every other day, or would you say the weekend only, or what would you normally tell people to do?
Well, so in my world, of course, the first thing is talking to the patient and really understanding their lifestyle, because, in integrative medicine, we're so interested in really being practical. And, if you give somebody something to do and they can't do it, then we've all wasted our time, right? So obviously this would depend on the person who's right there in front of me and is unique. That being said, in an ideal world, what I would not in an ideal world because they all would work, but really what seems to be easiest, let's call it, on a practical level is often time-restricted eating. Most people seem to find that easier. And for weight loss, I've seen it work really nicely. And if they can, let's say they're retired, generally it's for people who are retired, it's easier to do that earlier window. So 8 to 2 would really be ideal. I mean, if you look at, I know in Ireland, I have some patients and, traditionally they only have tea at night and they eat their, because in my family is French and, we used to eat our biggest meal at lunch actually, but now with modern life, it's switching to be closer to the US where now people are more eating their biggest meal at dinner. But really, if you can switch your intermittent fasting to be earlier in the day, and ideally in that 6 to 8 hour window, that seems to be easiest for patients, is to do time-restricted eating. And if they can do earlier in the day, it's better, but often they can't because they're working or they want to eat with their families or whatever.
Okay, I think you answered the next question with what you just said, that time-restricted eating, if you're going to pick a time that you're going to eat, it's better to do it in the morning than the evening.
Yeah, and a 6 to 8 hour windows is typical.
I will say at this point, Astrid, I will agree to do sunset to sunrise, or sunrise to sunset, but only in December. The next question is from Dr. Gluck. He has several questions, which is not
Awesome.
unusual for Dr. Gluck. Number one, how long on intermittent fasting until you see the beneficial effects?
Well, you can see in those studies, I mean, you were seeing it within a couple months. Yeah. Okay. So, I mean, in terms of weight loss, or you mean in terms of insulin sensitivity?
I think he didn't, he just said beneficial effects. So
Oh,
it could
okay.
be,
Well, I mean, okay, so, well, let's talk about inflammation reduction or something like that. That would happen very, very quickly because as soon as you start to see ketones, you're going to start to see a drop in inflammation, NF-kappa beta, all those cellular mechanisms we went through. So that happens with, and that's why, let's say with rheumatoid arthritis, traditionally they would fast for, in Scandinavia, have people fast for 7 days and then go to this diet, right? So you're going to see benefits for inflammation very quickly. And obviously for insulin sensitivity, similarly, but in terms of weight loss, we don't want people to lose weight too quickly. That's not great psychologically and also not good for the human system. But generally in the studies, you'll see weight loss by, within a couple months. Is that answering your question?
I think it did.
Okay.
Michael sent me a note if it didn't. He also asks, are there any crossover studies, same patients to compare inflammation and cognition?
Are there any crossover studies?
Crossover. So the same patients that do the intermittent fasting for a while and then cross over to stop doing it and compare their results.
There may be, and I may not have seen those studies. I mean, I did a fairly thorough review of the literature. I don't want to guarantee I know every single study out there, but I tried to present the very best quality ones. So I can't comment that I didn't miss one or something like that. And I did try to present the ones that had like the best reviews in terms of quality of study that was available.
Another question is, and this is great for you because you have such practical experience with it. Any tips to assist with success in intermittent fasting? How do you get them to succeed?
Okay, a lot of people worry that they worry about being hungry and so on, but actually what's been shown is that actually as you do it, ketones actually suppress appetite. So people worry about that, but really it ends up really not being an issue. And honestly, here's what I tell most people. Just go to bed a little bit hungry. Because then what happens if you go to bed a little bit hungry, if you're trying to lose weight, that is. I'm not saying to do this if you're not. But if you go to bed a little bit hungry, growth hormone, all these circadian rhythm hormones increase. And we know like growth hormone, for example, will build lean body mass. And that may be part of the reason that we see that increase in lean body mass. The other thing is, it's hard. What my clinical experience is, eating is always a social affair. It's not isolated. Literally, I do this all day for my job, talk to people about nutrition. And really, I'm always so happy when they come in with their families because it's harder to change things if your family's not on board. Like if you're not eating at dinner and everybody else is, we're missing out on that social and emotional and connection component, which is also really important. And, in integrative medicine, we hugely value that. So I would say also, even though officially in the studies it says we'll try to do earlier time-restricted eating, but also don't forget about that social and emotional component because, there's studies even showing, like one of my favorite studies actually is, there's a study from Japan where they took 2 groups of patients with type 2 diabetes. They fed them exactly the same meal and on different days. And basically people who watched a comedy show before the meal versus people who watched like a serious lecture, maybe like this one. And basically the ones with the comedy show had a much lower postprandial glucose over a number of hours than the people who watched the serious lecture. And it was for the same meal. So remember also that social and emotional component with eating is important and joy is important. And so choosing your time-restricted eating, if you're going to do that, to a place where you can also enjoy your relationships is good. That's what we would say in integrative medicine.
There's a question, which I'll answer, from David Weiss about whether we're able to share the video of the presentation. I think we'll be able to. Astrid in the past has let us publish this to our YouTube channel, but it's also shared via the MFH. throughout our system, and common spirit actually will have this as well. So that's the answer to that. There's another question, Astrid. Are you familiar with Dr. Esselstyn's, and I'm not sure if I'm pronouncing that right, Esselstyns, prevent and reverse heart disease? I guess it's a book or something. What's your take on this book? Are you familiar with that at all?
I am familiar with it, but I don't feel confident enough to speak on it right now because I would want to, properly research before I like to make sure that I have all my facts straight before I talk. So if that person could just email me, I'm more than happy to answer, you direct me, but I'd want to do research before I just, speak, just to do you justice and make sure I'm answering in the best way possible.
And for everybody, that's why we asked Dr. Pujari to address these types of issues, because she's so great in that regard. I have a question about there was a diabetic study where they did caloric restriction, but there was no weight loss. What's up with that? It makes me a little suspicious.
What type of caloric restriction? Was it daily caloric restriction
it
or
was
fasting?
It was the diabetic studies you showed, and you said the weight loss there was some weight loss, but you said it wasn't very significant, so it was more the caloric restriction was the point that was.
Oh, you mean in the ones I presented?
Yes.
Yeah. Well, you can, and people do, put like my cats. If they're left to themselves, they will gorge themselves on every single calorie, even if it's once a day, right? So you still, even if you're doing intermittent fasting, you still need to watch what you're doing in terms of caloric restriction. It's if your goal is weight loss, right? So, my cats are one example, but same applies to humans, right? If you have, 15 hamburgers in that time restricted window, you're still not going to lose weight, right? So right. I think there's something to that too. Thanks for pointing that out.
Mike Gluck also asked, can vigorous exercise stimulate intermittent fasting?
Yeah,
you can simulate, not stimulate.
Yeah, like marathon running and stuff like that. That's why they want to make sure they get glucose. For those endurance athletes, they take those glucose drinks and stuff like that. Yeah, you can get ketone formation.
There was a question about the restriction in diabetics for doing this. Is it restricted in both non-insulin dependent diabetics and insulin dependent diabetics?
Well,
do you have somebody just on metformin?
Okay, great question. That's a great question. I have had patients do this, time restricted eating, but obviously you've got to use your clinical judgment. I'm not saying anything you don't know here, but of course you wouldn't want them to develop hypoglycemia. So it depends on, you know your patient's story the best. And, for the talk, I need to put that there, but use your clinical judgment. The point is we don't want anyone getting hypoglycemia, of course, so that would be the reason. So you would have to use your clinical judgment with that. Because of course they did use it for prediabetes. And we know that obesity correlates with development and, continuation of diabetes and all the morbidities with that. So.
Another question about intermittent fasting. Are there any ethnic differences in response to intermittent fasting?
That's a great question. I don't know the answer to that. I didn't see that in any of the literature, but I don't know. We do know, for example, that in Asian populations, for example, in India, in East Asia, there's an increased risk of developing visceral adiposity even with normal weight. It's what we call in functional medicine or integrated medicine skinny fat, where somebody looks skinny, but they actually have a lot of visceral adiposity. And then that correlates. That's why, if you're looking at measuring waist circumference, they'll use a different criteria for waist circumference in Asian populations than they will, let's say, in Caucasian. And of course, that visceral adiposity, as we know, correlates to increased inflammation, increased insulin resistance, and all the, non-alcoholic fatty liver disease, et cetera. So there may be a difference, but I'm not aware of any studies that actually specifically looked at that.
There's another question about the eating window and whether a 12-hour eating window will provide any benefit. They said that because some people have to take medications with food and take them every 12 hours?
It's a great question. Actually, I looked at this study and I didn't put it up here, but they were trying in this study to see, okay, how can we make this more practical? Yes, even if you do a 12-hour window, it still will help. And also, they did a study that was really interesting where people just ate 2 meals a day. And just having 2 meals a day also helped. Or let's say helped may not be the right word. Created some of these benefits.
Great. I think that's about it, and we're at time. So thank you again, Dr. Pujari.
Thank you so much. Thank you.
Enlightening us. Oh, hold on. There's one more message, if you don't mind. Let me just see what, maybe just a thanks. No, here we go. I have been selectively recommending intermittent fasting for my patients, and I would say the success rate is still low, about 20% for meaningful weight loss. What's your impression in your clinic? I'm thinking if I could push myself to spend more time. I'm thinking whether I should push myself to spend more time on this or not. So are you getting better success than
Yeah,
the 20%?
much better. Really high success. But remember, this comes up with behavioral motivation all the time. You know, and you all know, like in primary care, when I was in my primary care practice, you know, I knew a lot of things, but it's hard to do that in 10 minutes, you know, and it's so much of it, of behavioral change, has very little to do with your actual recommendation. We focus a lot on, okay, this has got evidence, I'm going to tell people to do this, and then we sort of expect, oh, they're going to get it and they're going to do it. But we all know in practice, a lot of it is rapport and getting buy-in, and that is a time factor. So it may be in a primary care practice, it's repetition and repetition and repetition, because as we know, people don't, if there's not rapport there, it's hard for them to really believe it and to actually act on it. And that's a lot of, what we focus on in integrated medicine is how do we actually get somebody to make the changes that we know, all of us know would help them. But how do we actually get that to happen? And a lot of that is actually not about the actual intervention.
So true.
Yeah.
In all aspects of what we do.
Yeah.
Thank you very much.
Thank you.
There were 115 people on at the peak of this, and it shows the popularity of both Dr. Pujari as well as the topic is of great interest. So thank you very much.
Thank you very much. Thank you.
Have a great weekend.
You
people.
too.